Okay, so the next question is 25-year-old male, Purpura, diagnosed with ITP. Now, which of the following TKI can be used? So, first of all, even if you don't know the answer, if TKI has been asked, then the drug must end in some inhib form, enzyme inhibition. So, L-tremoboag is out, romistib is out, bosutinib and fosfatinib is there, and the answer is fosfatatinib, right? Because bosutinib is again a BCR ABL TKI. Where is BCR ABL TKI used? In CML, also ALL, also GIST. No, not GIST. In GIST TKIs are used but not BCR ABL TKI. Okay, so CML and ALL. Okay, so now coming to ITP, we'll discuss ITP in this question. So ITP treatment, first line is corticosteroids, IVIG or NTD. Second line includes TPO agonist. TPO agonist can be L-trombopac oral or romiplostim subcutaneous. How can you identify this on the exam? So trompo or platelet stimulation. So this is how you can identify. Rituximab is anti-CD20, splenectomy, and fosfamatinib, right? So let's discuss ITP in some more detail. Now the thing about ITP is what is happening, that there are these platelets. So in immune thrombocytopenia, what does immune thrombocytopenia mean? That there are some antibodies against our own platelets. So against what is the antibody formed? So the answer will be GP2B3A. GP2B3A. Next, what is happening, that spleen is consuming these platelets which are marked with this autoantibodies. Can say sort of opsonization. Now we are saying that spleen is consuming these platelets, but what exactly in spleen is consuming these platelets are the splenic macrophages. And where are the platelets being produced from? Bone marrow. And what specifically inside bone marrow? Megakaryocytes. So bone marrow produces platelets. These are being opsonized by our own antibodies, and then spleen macrophages are consuming them. Now, how are these treatment strategies designed? So first of all, from this pathophysiology, you can understand the findings also. See, if the platelets are being consumed here, so what will happen? Bone marrow will increase its platelet production, and you will see giant megakaryocytes in the bone marrow. So increase number of megakaryocytes on the bone marrow. Why? Because bone marrow has to increase production. Bone marrow is getting the signal that there are not enough platelets that are there in the circulation because they are being consumed by the splenic macrophages. So bone marrow increases the platelet production, and that's why the number of megakaryocytes in the bone marrow increase. Next, but you can say that this antibody we can test, which the autoantibody which is forming against the GP2B3A, you can sense this in the blood. You can take a sample and test for this, but the point is that the specificity and sensitivity of this test is very low. So this test is not very commonly used. Next, so these are the diagnostic findings. So diagnostic findings are increased megakaryocyte on bone marrow biopsy and decreased platelet count. I am saying these are diagnostic findings, but moreover, these are pointing towards the diagnosis of ITP. We have to rule out other causes of thrombocytopenia before coming to a diagnosis of immune thrombocytopenia. Next, what are the treatment strategies? So treatment strategies also revolve around these only. So one thing is, first line is steroids. Why steroids? Because they are decreasing the immune function overall, so they are decreasing the antibody production as well. Hence, these antibodies, these are being produced from B cells, right? B cells are producing these antibodies. Okay. Now, one thing is steroids can be used, right? Steroids, because they are decreasing the overall immune function. Next, we can stimulate this bone marrow to produce even more platelets. Who is doing this? TPO. Then these B cells can be reduced because they are producing these antibodies. Who is doing this? Rituximab. Next, we can reduce these splenic macrophages. So how can we reduce the splenic macrophages? So one is reduce their function. That was the question, that the TKI which is acting on the splenic macrophages, this is fosfatatinib, and which is being used in ITP. Next, what you can do is splenectomy. If nothing is working, you can just remove the spleen and the number of platelets will increase, right? So some important points from Robbins that may be asked, that age and demographics in chronic ITP and acute ITP, they differ. Chronic ITP is typically an adult woman. Female to male ratio is 3:1. while acute ITP is a childhood disease and equal frequency in both the sexes. This is 1:1. So they may design a question and write that in acute ITP the female to male ratio is 3:1. The answer will be that it is not a correct statement, because in acute ITP there is equal frequency in both the sexes. Then chronic is chronic, acute is acute, but the thing about acute is that it usually resolves within 6 months and no drug needs to be given. If the platelet count is not very low, for example in dengue, say in dengue the platelet level is 50,000, so the platelets have decreased, but we need not give any specific drug or any platelet infusion, as long as the platelet count is fine, and we know that once the viral infection is gone, our platelet count will recover, so we need not give any drug specifically for that. However, in chronic ITP steroids are usually given because it doesn't recover on its own. So one thing about chronic ITP is that if you see splenomegaly or lymphadenopathy in chronic ITP patient, you test for upper abdomen examination and a general physical examination, and you see splenomegaly and lymphadenopathy, then you need to suspect other causes such as a B cell neoplasm, because in plain chronic ITP there is no reason for splenomegaly or lymphadenopathy to occur. Then glucocorticoids is a standard treatment, while in acute ITP I have already explained these are given only if the thrombocytopenia is severe. So this is ITP for you.